on osteoporosis in diabetic women. Dr. Usha Sriram.
Thank you so much. Thank you again. So this is, I think, a really important topic, and I must thank the organizers for including it in the program, diabetes and bone health. So this will start with a clinical scenario. A 66-year-old Mrs. Gupta is admitted to the hospital with a history of fall from a very short step stool and is found to have a hip fracture. And her risk factors for osteoporotic hip fracture is that she's postmenopausal. There is no family history of osteoporosis, no history of rheumatoid arthritis, or steroid use, or premature menopause, or cancer, malabsorption, anything that we routinely talk about. And she had a very stormy, difficult post-op course. She had a PE and ARDS and barely survived. It's actually a real patient of somebody I got consulted on for osteoporosis. So the question is, why did she fracture her hip, and what should and what could have been done for her? So she has type 2 diabetes for the past 12 years, and she's been on the following medications. Initially on metformin, glimepiride, and pioglitazone for the past 7 years, and voglibose was added for the past 4 years, and basal insulin also for the past 1 year, plus rosuvastatin and telmisartan, low-dose aspirin. She does her annual eye exams, maintains her A1C somewhere between 7 and 8. But the truth is, she's never undergone evaluation for bone health and has never been on calcium. So all I want to say is it's kind of a crying shame that we do everything else for improving the glucose control, but something like bone health has been left out. And it's not just a holistic global care. What I'm going to show you is that one of the complications of, if you think of osteoporosis and fractures as actually one of the complications of diabetes, an unsung complication, so to speak. So just to show you that there are many things that are contributing to increased risk of fractures, which is from hormonal changes, increased growth factors like IGF-1, particularly type 1 or insulin deficient patients, hypogonadism, vitamin D deficiency, and then they may have other complications, autonomic neuropathy, retinopathy, hypoglycemia, which increases their risk of falls, and then altered body composition, decreased lean body mass, and we all know that muscle translates into bone health, increased marrow and skeletal fat. In fact, they're talking about is osteoporosis the obesity of bone. I'll show you an interesting cartoon for that. And then there are some novel mechanisms like advanced glycation end products and oxidative stress and inflammation also contributing. So all of these things, and then not to forget medications. Medication, we've known about TCBs, but now the SGLT2, especially enagliflozin, has also come into the picture in terms of increasing the risk of fractures. So the connection, both are highly prevalent. Risk of both increases with age. Both are usually asymptomatic unless you look for it. And both are associated with very serious consequences, mortality and cost. And diabetes in itself is a big risk factor for osteoporosis. And complications of diabetes, like I mentioned, like vision problems or loss of balance or hypoglycemia could increase risk of falls and fracture. And both are preventable. So that's what I want to talk about. So just projected risk of hip fractures, as you can see, many millions more by 2050. Same thing we see with type 2 diabetes. But it is associated with increased morbidity and mortality. You can see death, permanent disability, and then many people never return to their previous level of functionality, and then they are unable to carry out at least one independent activity of daily living, and of course it's also an expensive complication. We've always known osteoporosis as a skeletal disorder that is compromised by low bone mass, but the NIH changed the definition to say that it's characterized by compromised bone strength, predisposing to increased risk of fracture. And this is a really important step in the definition of osteoporosis, because bone strength is reflective of both bone mass and bone quality. Because we know in and you can see whether it's microarchitecture or the porosity, geometry, size, turnover, damage accumulation, mineralization, degree of mineralization. Everything is contributing to bone quality, which seems to be affected in patients with diabetes. Just to show it in the form of a cartoon, the components of bone quality. We all know that there's changes in bone density with age. Peak bone mass is reached in our late teens or early 20s. So if there is type 1 diabetes or type 2 diabetes at a young age, you can see what can happen to their peak bone mass, and then there's a plateau for a while. But if they are insulin deficient, or they have other complications, or nutritional issues, or other autoimmune disorders, this plateau may be an issue, may be lower. And then if they have premature menopause, there is going to be a rapid fall, and then the complications of the effect of diabetes itself or advanced glycation end products. All of these things could make the fracture threshold much earlier than it would happen in a person who didn't have any of this. So normally if somebody would fracture in their 70s or 80s, you can imagine that they can fracture in their 50s and 60s, which is what happened to Mrs. Gupta. And bone remodeling, as you can see, bone is not a dead tissue like it looks like, but actually a very vibrant thing that keeps remodeling constantly. Every minute it's doing things. So the normal process is there is, there are lining cells, there's activation, then osteoclasts are there, they come up and eat up the bone, and then the osteoclasts come and fill in that thing, then mineralization takes place, and this thing keeps going on, and it takes about 3 months. There just seems to be more, if you have more bone resorption, or more osteoclastic activity, or less osteoclastic activity, or less mineralization, all of these things would lead to a bone that is not healthy and fracture easily. So, like I mentioned earlier, many things contribute towards an osteoporotic fracture. We also know that there are multiple risk factors for osteoporosis. Aging is a very significant one. Postmenopausal state is a very significant one. But there are multiple medical conditions, multiple medications one can be on that can lead to increased risk of osteoporosis and fractures. And I want you to see under endocrine disorders, they talk about diabetes. But I think it's actually somehow has not had its place in the prime time, and really we should bring it there. And many other things, many lifestyle factors, low calcium intake, high caffeine intake, increased intake of alcohol, so many things, immobilization, thinness of stature, all of this contributes to increased risk of fractures. Under medications, you may not see the oral hypoglycemic agents that we are talking about, particularly TCDs and the SGLT2 inhibitors, canagliflozin particularly. But these are things that we must keep in mind, because if somebody is at risk or has had a previous fracture or a risk for osteoporosis, then we should seriously consider not using these medications. Or if you have a postmenopausal lady, please assess their fracture risk first before considering the medications that you want to use. What kind of laboratory evaluation and imaging you want to do in a patient? You want to check on their calcium and albumin, because occasionally it could be someone with hyperparathyroidism that could present with osteoporosis. You want to get a CBC to make sure that they don't have anemia, which could be reflective of something else going on, like a myeloma or malabsorption or plain and simple nutritional deficiency. You want to check vitamin D, because 50% of patients with osteoporosis have an osteomalacic component. So fixing that, optimizing that vitamin D is very important, one reason. Another reason is, if you have somebody with vitamin D deficiency and you give them a bisphosphonate, you could actually give them more bone veins, or you could even drive their serum calcium down considerably. So you must optimize their vitamin D before giving them, or check and optimize vitamin D before giving them a bisphosphonate. The other tests listed here are targeted testing. Only if you have clinical suspicion, you want to do those things. But if there is one test, if you ask me, that you must do, it's a spine X-ray. Because if you fracture your hip or you fracture your arm, you will always know about it and you'll come and see the doctor. Spine fractures are something that is missed all the time, and it may not present clinically except as a vague back pain that people will ignore as back strain or something. So unless we do an X-ray, we never find it. The reason why we have to find it is, if you find a vertebral fracture, you put them in a different risk category. Let's say you do a bone density and you find osteopenia, but they also have a vertebral fracture. Completely goes into a different risk category for treatment. Also, if somebody has incident vertebral fracture, the risk of future fractures are much higher. So you want to treat them more aggressively. So getting a spine X-ray is really, really important. If you have the facility to do a bone density, that's great, and especially if it has a vertebral fracture assessment, that's even better. So that is something that you can do. Things like bone biopsies and bone scans are not something that are routinely done in assessment of osteoporosis. So the diagnosis of osteoporosis is still something that we follow the WHO guidelines, which says if the bone density is less than -1, up to -1, the patient is normal, the bone density is normal, -1 to -2.5 T-score, it's called osteopenia, and anything that's worse than -2.5 is called osteoporosis. That is the T-score. We use T-score to compare the person to a younger, usually a 30-year-old sex-matched individual. A Z-score is something that you compare to an age and sex-matched individual, and that helps us usually to find out secondary causes of osteoporosis. You take a 70-year-old lady, and if she has a low T-score, it's understandable. But if her Z-score is also low, you know something else is going on, and you have to think in terms of looking for secondary causes. But keep in mind that most women with hip fractures do not have a T-score less than 2.5. This is the NORA data. So you also have to be cognizant of this and look at osteopenia also seriously. If you don't have the facility to do a DEXA, or the patient is resource poor, you can always do what's called a FRAC score, which is just putting in the risk factors, and it gives you a risk assessment. If you look into these things, there is no diabetes here. How to assess risk with the FRAC score? So recently, the FRAC people have made a recommendation. You can put in rheumatoid arthritis. Anytime you have a patient with diabetes, put in rheumatoid arthritis. Then it will give you the risk for fractures, 10-year risk of fractures. So a few things about what happens to bone health in diabetes itself. We know that both in type 1 and type 2, there is an increased risk of fractures. Meta-analysis in type 1 shows a risk ratio of 6.9 of hip fracture, and in type 2, it's less than the 6.9. Usually it is somewhere in the 1.7 to 2 range that we are seeing. And other risk factors are microvascular, ophthalmic, neurologic, which I've already mentioned, and nutritional, which is very, very important. So this cartoon kind of nicely summarizes all the things that are going on in a diabetic patient that is influencing their bone quality. You can see there what's happening in terms of their osteoclast. See, the glucose, high glucose in advanced glycation products, glucose itself has an effect on osteoclast. It also has an effect on osteocalcin, has an effect on type 1 collagen. You can see retinopathy and hypoglycemia and neuropathy, cardiovascular disease, increasing the risk of falls. You can look on the other side, which is something really important to keep in mind, is these cells are coming from a common progenitor cell. So they could go to the adipocyte way, or they can go the bone way. They should go both ways. But many times what can happen is they go the adipocyte way, and therefore the bone cells are compromised. And you know that factors like insulin and other growth factors, IGF-1, are low in patients with diabetes. So that also impacts on bone quality. So diabetes diabetes control is important, bone quality, vision, balance, hypos, obesity, and nutrition. And I want to show you what happens with glucose control. Glucose itself is toxic to osteoblasts, impairs the synthesis of osteocalcin, and histomorphometry has shown no bone formation in patients with diabetes. Again, just to show you what happens when to the uncarboxylated osteocalcin, it seems to have an effect on the beta cell and the adipocytes. So osteocalcin's role, in insulin secretion is something that we are looking at now. Now, this explains some of the effect of medications like TZDs. What it does is it will direct it into the adipose cells. We know people who go on TZDs gain more fat, and therefore they have less bone. And the other thing that I want to talk about is the obesity, diabetes, osteoporosis nexus. Whether it's overweight, mild obesity, or severe obesity, you can see there is increased risk of osteopenia and osteoporosis. And this is what I was referring to, osteoporosis and obesity. All kinds of things, whether it's inflammatory cytokines or the other mechanisms I mentioned, seem to affect osteoclasts and osteoblasts and direct it in the adipocyte formation. And the third one is nutrition. This again is BMI. When the BMI is high, there also seems to be less vitamin D. So we don't know whether they're sitting indoors and therefore they're overweight and vitamin D deficient or some other connection, but there is a connection. And it's very, very important to keep vitamin D all the time in mind, because I said 50% of patients who are osteoporotic also have osteomalacia, and we need to correct that first. How do we treat these patients with diabetes? You give calcium, make sure at least you give them 500 milligrams a day with vitamin D. Some people may require higher based upon their nutritional intake, and make sure that they get adequate vitamin D. If they are vitamin D deficient, we need to bring it up to speed with high dose vitamin D for a few weeks, about 8 weeks, and then once a month for a few months, and then maintenance therapy. Anti-resorptives like bisphosphonates have shown to be of benefit, whether it's oral or zoledronic acid, beneficial in patients with diabetes. And if they are not effective, or if somebody fractures on a bisphosphonate, or they continue to lose bone on a bisphosphonate, or they don't tolerate it, you can consider anabolic like PTH. And optimum vitamin D levels are something you know. There's a lot of debate about it. You need to keep it at least a minimum of 20. 30 would be ideal. So just coming to the last couple of slides. So I talked about bisphosphonates and parathyroid hormone. These are the only two things really that's now recommended and available for any osteoporosis therapy. Same thing applies to people with diabetes. So, and the subgroup analysis is also shown to be benefit. My last two slides, I think, are the most important thing that we can do for our patients is fall prevention strategies. You need to spend at least 5 minutes going through each one of these with them, that they need to leave the light on in the bathroom, make sure that there are no wires or rugs, or they cannot walk on a slippery surface. What all they need to do, you need to go through that checklist so they don't have a fall. So in summary, glycemic control is very important. We have to assess their fracture risk, calcium supplementation and vitamin D optimization, anti-resorptives like alendronate or azitronate or zoledronic acid. Otherwise, you can go to anabolics, fall prevention, reassess the bone density every couple of years and see their response to therapy, reinforce adherence to therapy, which is very important, optimize their weight, and careful selection of anti-diabetes drug. Meaning, avoid the drugs that increase the risk of bone loss. We don't choose the drug that improves bone yet. We're not there yet. I think we have other good medications for bone health, but we want to avoid the ones that can make it worse. So this is